What are the treatment options for pelvic floor disorders? It depends on the pelvic floor disorder. So if we take them by subtype, pelvic organ prolapse, which is the feeling of a bulge from the vagina, can be almost always treated with three options. The first is to do nothing, and I'd say a lot of my patients are just reassured when I tell them it's not dangerous. The second is wear a pessary, which is much like a bulky diaphragm. It's something we fit for the woman. They wear in the vagina, take it out periodically and wash it and put back in. If it's fit properly, it doesn't come out and it's comfortable. The advantage is it's not surgery, it's non-invasive. The disadvantage is that it doesn't cure it, and some women don't want to deal with it their whole life. And the third options are surgeries, and surgeries are all over the gamut. This may be the hardest part, counseling a woman. We talk about starting at the beginning if someone wants surgery. There are surgeries that obliterate or close the vagina if a woman's older and not sexually active. The majorities of surgeries are reconstructive, trying to rebuild the vagina. For women who have a uterus, you can remove the uterus if it prolapses and pull the vagina up. You can leave a uterus in and suspend a uterus. You can use mesh, which anymore sounds like a dirty word, but there are many good procedures with mesh, or you can use non-mesh procedures, and all of these have pros and cons. For incontinence of urine, it depends on what kind of leakage they have. Most women have either stress urinary incontinence, which is defined really as a leakage of urine with movement and not urge. The typical patient says, I jump on a trampoline, I cough, I jump and I leak. The other kind of leakage is what we think of as overactive bladder, and that's urge incontinence. I can't get there on time, I get up at night, I go frequently. They're caused by different things and they're treated entirely differently. So getting a good history and figuring out which one, although both can bother women, but which one bothers them the most helps. Starting with the leakage with cough, the stress incontinence, the treatment options are, we always encourage women to avoid constipation, maintain a healthy weight, don't smoke, and this goes across really all pelvic floor disorders. Beyond that, pelvic floor strengthening, Kegel exercises, best done with a pelvic floor physical therapist. This is good for all patients, but for treatment, it's usually best for your patient with more mild stress incontinence. For patients with more moderate to severe, they usually require something else. There are pessaries that are specially designed to help push on the urethra to help with leakage, and then there's surgeries. Slings are probably the most common surgery we do. Slings by themselves are outpatient, but they can be combined with larger surgeries. For the other kind of leakage, which is more urgency leakage, that's typically non-surgical. This is starting at the top, avoiding bladder irritants like caffeine and carbonation and citrus, avoid constipation, don't smoke, lose weight if you need to. Physical therapy, but instead of Kegels, it's learning how to control the urge. And then the next treatment is medications, and that's the medications we see ads for, the gotta go medications. For patients who fail medications, though, what's exciting is, especially in the last few years, there's some other great options. Nerve modulation's been around for a long time, but the studies have even gotten stronger. It's now recognized by the American Urologic Association as a good third-line agent. There's nerve modulation where we put a lead into the back, has great success rates. There's an office procedure where you can come in once a week for 12 weeks and get a tiny wire in your ankle for 30 minutes. And then there's Botox injections in the bladder, which is the newest player. As a urogynecologist, I rely on a really good, strong pelvic floor physical therapist. There are some all over, and we try to get them close to where patients live. I have several patients that travel, but we have great ones here at St. Vincent, and those are probably the core of who I believe in. Pelvic floor physical therapists do a lot with patients depending on their complaints. Pelvic floor pain, muscle pain, is a big thing we see. It's a strange entity because the pelvic floor has muscles that hold up the uterus and the bladder and surround the urethra and the vagina and the rectum. We don't know why these muscles spasm. Sometimes it's brought on by a painful event, but it's really difficult to treat without physical therapy. And you need a really well-trained pelvic floor physical therapist who does hands-on physical therapy to help that patient learn to relax. It's much like having a Charlie horse in your calf, but down in your pelvis, and it can be incredibly uncomfortable. Physical therapists also can work on patients on teaching them how to do a proper Kegel exercise. There are studies that we are very good about telling patients to do Kegels, but that most women don't know how to do them correctly. So a good pelvic floor physical therapist will teach a woman how to do a Kegel and then do more than just the typical Kegel, but teach them how to mobilize the pelvic floor to strengthen it. And pelvic floor exercises can help with incontinence and prolapse and general pelvic floor health. For overactive bladder, it's a little different. Kegels are important because you need to be able to find those muscles, you need to be able to use them. But this is a different pathology. This isn't urine sneaking out when you cough. This is the bladder contracting when it shouldn't. That's the urgency. So a good pelvic floor physical therapist will know the difference. We'll be able to work with a woman to encourage her to avoid bladder irritants, but then to use some normal reflexes that your body has to help control the urge as opposed to just hold it in with the urge. And there's some complex dynamics that a good pelvic floor physical therapist will understand. And these are called urge strategies and bladder retraining. And they can work with a patient on that over. Sometimes it takes several months to get this under control.